A Sudan black, right over color.
So,
Sudan black B fat stain of the stool is positive. Sudan black B. Okay. Colonoscopy with biopsy of the terminal ileum shows inflammation with granuloma formation. Um, which of the following is most likely mechanism of this patient's steatorrhea? Most likely mechanism. Okay.
is Sudan black is goes for Whipple?
Probably, yeah. For mixing of vitals and data relatives. Mm, really?
Yes.
Mm, where am I? Oh,
Oh,
nope, was not with.
am I misguiding you?
No, no, no. I didn't. I had no idea. So that's why I went with no, no, no. I had no idea on that
Okay.
this one.
Okay. Crohn's disease is characterized by transmural inflammation of the GI tract, most recently involving the terminal ileum. It can arise anywhere in the GIT and is subclass of inflammatory bowel disease. Most patients experience chronic abdominal pain, bloody diarrhea, weight loss. Examination often shows generalized abdominal tenderness, sometimes worse in the right lower quadrant. Extraintestinal manifestations such as uveitis, severe Crohn's disease can result in intestinal obstruction from stricture or inflammation, bowel perforation, intraabdominal abscess, and the formation of the fistula. Crohn's disease may manifest as steatorrhea caused by the impairment of the bile salt resorption secondary to inflammation to the terminal ileum. Bile salts play a crucial role in the solubilization of the fat in the enteric lumen and are recycled through the enterohepatic circulation, which is dependent on the resorption of the bile salt through an intact ileal mucosa. Impairment of the bile salt. Impairment of the bile salt resorption because of ileal inflammation can overwhelm the ability of the liver to synthesize de novo bile acid, resulting in a deficiency of fat-soluble vitamin absorption. Patients with Crohn's disease should undergo frequent evaluation for deficiency of fat-soluble vitamins. I don't
Okay.
understand
Can you read A
the relation.
sorry, what did you say?
Like I don't have the clue how
I think here the key was the granuloma formation.
Crohn's causing granuloma. Okay. Okay.
Oh, the key here was granuloma.
Yes. Okay.
Do you remember Crohn is one of the non,
Okay.
is it
Yes.
right? Non-granulomatous. I think the confusion here was the fat
Sudans.
fat thingy.
Yes.
Like because Crohn we are used to doing bloody diarrhea. Crohn is usually bloody diarrhea, so that's where we got confused.
Ulcerative is usually bloody. Crohn's is usually watery.
Oh,
But
Crohn's is watery?
yes. But in here they are talking about the
Oh,
loose stool, like fatty stool. And fatty stool goes for the Whipple. Okay, I'm reading option A. Okay, which option you are talking about?
A and E.
Okay, a bacterial overgrowth of the small bowel. Bacterial overgrowth of the small bowel may occur in the setting of prior abdominal surgery. Or prolonged proton pump inhibitors. This patient's presentation is more suggestive of fat malabsorption related to Crohn's disease. And poor mixing of the bile acid with dietary lipids is incorrect. Deficient resorption of the bile salt. rather than defective formation of the micelle is the primary cause of steatorrhea in patients with Crohn's disease.
Okay. I guess Crohn's also can present with steatorrhea.
Steatorrhea.
I did not that. Okay. Um, 37 woman comes to physician because 1 week history of progressive left-sided facial pain and swelling, left-sided. Initially, the pain was only precipitated by eating, but now has been caused then for the past 3 days. Okay, has no history of serious illness, no medication, temperature fine, pulse fine, respiration fine, BP fine. Exam shows area of edema over the lateral left face that is warm, then the red. Diagnosis, left sided.
This is one tender response.
Ready?
1 minute.
Got it.
Okay, okay. Okay, sialadenitis refers to inflammation of the salivary gland. Sialadenitis refers to inflammation of the salivary gland and typically presents with acute onset pain and swelling over the affected gland. Acute sialadenitis often persists for several weeks and most commonly occurs because of obstruction of the gland caused by sialolithiasis, but may also occur secondary to viral infection, mumps, Epstein-Barr virus, bacterial infection, most commonly Staph aureus or strictures following radiography. The presence of constitutional symptoms may be indicative of viral cause, while the expression of purulent discharge from the glandular surface may indicate the bacterial infection. These patients' history of pain precipitated by meals and is most suggestive of the presence of salivary gland stone causing intermittent obstruction. Further evaluation with ultrasonography or CT may help establish the diagnosis. Treatment is primarily conservative with analgesic and application of heat and massage and dehydration. Patients that fail to improve with conservative management sometimes require removal of the sialolith if present, usually sialoendoscopy.
Next. Obese 42 woman has an episode of colicky pain in the right upper quadrant of the abdomen that lasts like 2 hours and subsides spontaneously. She has no fever or leukocytosis, no signs of peritoneal irritation. In the right upper quadrant, liver function test is normal. Ultrasound shows gallstones. Which of the following is the most likely cause of the abdominal pain? Ready?
Okay, okay. These patients presenting symptoms of colicky pain in the right upper quadrant. These patients presenting symptom of colicky pain in the right upper quadrant and is consistent with the biliary colic secondary to transitory obstruction of the cystic duct by gallstone. The pain is typically the pain is typically dull, severe. The pain is typically dull, severe, triggered by meals and may radiate to the right shoulder. If the gallstone is passed into the common bile duct, if the gallstone is passed into the common bile duct, biliary obstruction may ensue and leading to jaundice, hepatic injury, and acute cholangitis. Most episodes of biliary colic last several hours before subsiding spontaneously. Biliary colic can be distinguished from cholecystitis by a lack of fever and a normal abdominal appendix and a normal abdominal examination and lack of leukocytosis. Abdominal ultrasonography can aid the diagnosis. Abdominal ultrasonography can aid the diagnosis by identifying the presence of the gallstone, provided that the clinical picture and the examinations are improving. The acute management of the biliary colic is generally conservative with oral analgesia. Elective cholecystectomy is recommended to prevent further complication from the gallstone. If symptoms of biliary colic if symptoms of biliary colic progress to show features of jaundice, hepatic injury, cholecystitis, pancreatitis, cholelithiasis, cholangitis, operative cholecystectomy, or interventional endoscopic retrograde cholangiopancreatography management should take the place.
Can you read BC?
Yes. Bacterial growth in the bile within the bacterial growth in bile within the common hepatic duct may result from an ascending infection of the biliary tree known as cholangitis, which typically occurs in the setting of the biliary instrumentation or cholelithiasis. Acute cholangitis presents with fever, jaundice in addition to the abdominal pain. Acute cholangitis presents with fever, jaundice in addition to the abdominal pain, Charcot tract, and possibly with shock and altered mental status, Shane or Spencer. Okay, both within the common hepatic duct. Okay, cholangitis. Okay, A and C. Okay, transitory chemical reaction of the gallbladder wall may occur in the setting of intra-arterial chemotherapeutic embolization of the hepatic metastasis, typically performed by interventional radiology, collateral and or aberrant anatomic flow may result in the inadvertent doses of the chemotherapeutic agents of the gallbladder, which results in transient inflammatory symptoms that typically self-resolves. The presence of gallstone and the colicky nature of the patient's pain are more consistent with biliary colic.
I've never heard of that transitory chemical thing.
Transitory. Okay, can you just summarize these things, like
Which
the whole thing, like bacterial growth in the bile duct, like what can I say? When we see the option, what would be its diagnosis? Like that. You got my point. Like bacterial growth in the bile within the common hepatic duct. Like option A,
uh-huh,
it
uh-huh,
is for cholangitis, inflammation of
cholangitis
the biliary tree, or inflammation of, where is the inflammation? Infection of the
in
biliary
the,
tree.
in the common bile duct.
Okay, so if in the bacterial growth or something in the common bile duct, that is cholangitis.
Mm-hmm.
And bacterial invasion of the gallbladder wall, what does it mean? Like echo, just uh, click this picture and just tell
Which one?
this one. This bile duct. Okay, this one. So where the obstruction happens and what would be it called? Like if the obstruction occurs in the common bile duct, that is cholangitis.
Common
This one.
bile duct is
Yeah.
cholangitis. Okay.
And if it is happens in the cystic duct, or is there anything name?
Yeah, that's called a biliary colic. What we
Like
just saw. Mhm.
like
What we
obstruction in the cystic duct is biliary colic.
yeah, colicky pain. Yeah.
Okay, biliary colic. Okay, then the transient obstruction in the common hepatic duct.
Oh, the common hepatic duct is seen that that one is the one that's cholangitis, common hepatic duct. So, oh my goodness, what is it?
Common
So
hepatic
this,
duct, there may be bacterial growth, there may be obstruction.
uh, mm, so the bacterial growth, it says here, bacterial growth in the common hepatic duct may result from ascending infection of the biliary tree, known as cholangitis.
And what is cholecystitis?
Cholecystitis is, from what I think, is um,
Like
obstruction in the cystic
in the
duct.
gallbladder wall or gallbladder.
No, I thought it was when the thing is obstructed here, so then the bacteria invades the.
In the cystic duct,
Yeah.
just near the opening. Like
Yes. So it's blocked, so then everything backs up here inside, and then
yes,
the bacteria can come in and cause inflammation of the bile that's inside the cystic duct because it's blocked. The bile cannot go out. I thought that was cholecystitis, or
okay.
am I wrong?
No, no, you are right.
Okay. Okay, then what else?
Like option C, transient chemical irritation of the gallbladder wall. Is it cholecystitis? Like option C.
No, 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 no. That one is saying that this is not like it's not like an infection. It's something to do with chemo, like chemo. Say that doesn't. I've never. That's why I was telling you to read that. I've never heard about that. That's not. I don't think I've ever seen it in any question beside this one. So
Okay.
don't worry about that
So
one. Yeah, that
chemical
one.
irritation is like uh, chemotherapeutic embolization of
Yeah,
hepatocyte.
kind of therapy.
Okay.
Okay,
And
so yeah.
cholecystitis is bacterial invasion of the gallbladder wall.
So there should be an obstruction of the
Obstruction.
system first, and then the bacteria can invade. What else? I think we got all of them right.
Yes.
Okay. And then choledocholithiasis, what would that be?
Uh, I don't remember. Cholidoko.
Right here. Yeah.
Where?
Right here. It's a
Yes.
choledocholithiasis.
In the common hepatic duct.
Come on, hepatic
So
duct.
everything is in the common hepatic duct.
No, because this one, where is it? Here it says bacteria growth in the common hepatic duct. But here is just, I guess, just obstruction
So obstruction by the stone is
by a stone.
cholidoko. Lit means stone. Okay. Obstruction by stone is cholelithiasis. And like infection in the biliary tree, that is cholangitis.
Okay. Yeah. Okay. Yep. You got it. Okay. Yeah, those Coley
So
things,
now, so this patient has cholelithiasis.
no, this patient has just uh, biliary colic. His thing doesn't go all the way down.
Okay.
His obstruction doesn't go all the way down here. His obstruction is just right here.
Cystic duct. Okay.
Yeah, so his obstruction doesn't go. That's why the question said that his liver is fine, pancreas, everything else is fine because the obstruction is just here. If the obstruction was here, then the liver will have a problem because you see everything will back up here, will back up here, will back up everywhere. But his obstruction is just here, so the liver is fine.
Okay.
Mhm. Okay. Next, 52 men comes to physician because of 4-month history of loose, foul-smelling stool. During this period, he has also had like 14 weight loss despite good appetite. He also has had urinary frequency and urgency for 3 weeks. Okay. No fever, chills, nausea, vomiting. He has 10-year history of recurrent alcoholic pancreatitis that required hospitalization once or twice a year because severe abdominal pain. He has not been hospitalized since he abstained from alcohol 2 years ago. But he has had chronic mild epigastric pain since that time. Okay. During his last hospitalization 2 years ago, X-ray of the abdomen showed calcification in the pancreas. BMI is fine. Exam shows temporal wasting. Cardiopulmonary exam is fine. Abdomen shows mid-epigastric tendons and no masses. No hepatosplenomegaly. Bowel sounds normal. There is no peripheral edema. Labs, hematocrit, I believe that's low. MCV is normal. Leukocyte count, normal. Segmented neutrophil. I don't know why I believe this is high. Let me see. Where is it? Neutrophils. Yeah, it's high. Lymphocytes normal. Monocytes. Wait, I think monocytes is high too. Yeah, monocytes is high too. Platelet count normal. Let me see hematocrit. Hematocrit is low. Serum urea is uh, always takes me time. Normal glucose is high. Creatinine is I believe is normal. Protein is 5.8 normal and albumin is low. Which of the following sets of findings is the most likely explanation for this patient's increased serum glucose concentration? So what's causing the high glucose? Oh, let me go back down. Okay. For this patient, insulin production. What does he even have?
Uh, uh, One of the thing I am thinking, like, maybe I don't know. Is it glucagonoma?
Glucagonoma,
Glucagonoma,
glucagonoma.
glucagonoma makes you
Mhm.
sad. Steatoria, diarrhea, diabetes.
Isn't the glucagonoma the one that comes with rash,
With the
with the rash, with some kind of rash?
yes, necrotic migratory,
Yeah, it
necrolytic
doesn't,
migratory something something.
it doesn't look like glucagonoma. It looks like some kind of cancer. Because you say he's losing weight. I mean, he's not BMI is fine, but he has temporal wasting and whatever, and a bunch of pancreatitis, and maybe I'm wrong.
If it is pancreatitis, like where you are thinking about chronic pancreatitis,
Kinda.
there is calcification in the pancreas, so chronic pancreatitis can happen. So in chronic pancreatitis, insulin would be high.
Chronic pancreatitis. Insulin will be high.
Yes.
Oh,
What do you think?
I think it will be. I mean, doesn't the pancreas produce insulin? So if pancreas is having a problem, insulin will be low, right? Or no? Am I wrong?
Maybe low.
I don't know. I don't know.
Why
But then for me,
like they are talking about why there is increased serum glucose concentration.
yeah, this doesn't.
This doesn't is like high insulin causing low glucose. Sorry, high insulin causing high glucose. Is it contradictory? Isn't it?
Yeah, see, it couldn't be high insulin then because then there will be low glucose.
Yes. So in
Or
here
no?
glucose is high. Now glucagon, if glucagon is high, then glucose can be high.
Yeah. But I don't understand the monocytes and all that. Why is it high in the neutrophils? If he does, like, it seems like he has some kind of infection. Let's just pick one. This is not. There is no way we can figure this one out.
Okay,
Okay,
just guess. I
I
think
do.
I am thinking B.
No,
Okay,
I got it right. He was
you
saying
are
it's probably some kind of cancer.
so you are right. You are thinking about chronic pancreatitis.
I mean, we know it's chronic it says it on the question that he has some kind of chronic pancreatitis with the you to see the
Yes,
calcification and stuff.
calcification.
Yeah, but I just didn't know like if he
Glucose
had
should be,
something to do
sorry,
with
insulin should be low.
yeah, if asking, yeah. Like insulin, everything that pancreas produces will be low. Glucagon, insulin, everything will be low. But he doesn't have diabetes, so the insulin response will be normal.
Yes.
Mhm.
Okay. Recurrent acute pancreatitis may lead recurrent recurrent acute pancreatitis may lead to chronic pancreatitis. Recurrent acute pancreatitis may lead to chronic pancreatitis and insufficiency of both the exocrine and endocrine. Both the exocrine and endocrine functions. The exocrine pancreas produce digestive enzyme. The exocrine pancreas produces digestive enzyme, and the absence of which lead to malnutrition, cachexia, muscle wasting, weight loss, vitamin deficiency, and frequent loose, foul smelling, sometimes oily steatorrhea. The endocrine pancreas produces insulin, glucagon, and somatostatin. The loss of endogenous insulin leads to development of diabetes mellitus, with symptoms including polyuria, polydipsia, polyphagia. In the scenario of pancreatic production of the insulin and the glucagon are decreased while the peripheral insulin response is normal. The diagnosis of the chronic pancreatitis and pancreatic insufficiency is thorough clinical history, imaging, biopsy. Exocrine pancreatic insufficiency is treated with oral pancreatic enzyme and fat-soluble vitamin replacement. Additionally, the development of diabetes mellitus caused by the loss of the pancreatic insulin requires insulin replacement. Any modifiable inciting cause of pancreatitis, gallstone, alcohol abuse, hypertriglyceridemia, or hypercalcemia should be mitigated to delay the disease progression and preserve remaining native pancreatic function.
We still don't know what the leukocyte, the neutrophil count was had. That was distracting to me. Like why the
Is
neutrophil
there
and
no
monocytes
option
were
of, okay,
because that's what distracted me. I was like, wait, am I miss? Is there some kind of infection or something? Okay. Anyway, 23 woman comes to office because 6 week history of fatigue and swelling of her eyelids, ankles and feet swelling. Okay. She has no history of serious illness, no medication, BMI fine. She's 5'4". Vital signs fine. Exam shows 2 plus periorbital edema and 3 plus pedal edema. No other abnormalities noted. Fasting serum study show total cholesterol, which I believe is high. Tags concentration, I believe, is high too. This patient is at greater risk for which of the following complication?
TG concentration is greater than 400. The agent is at greater risk of 6.
Ready?
One sec. Is it hypothyroidism?
I don't believe so. Maybe, but I don't think so.
Okay.
Let's see. Maybe you are right. No, nephrotic, yeah.
Nephrotic syndrome is characterized by edema secondary to excessive proteinuria resulting in hypoalbuminemia and diminished oncotic pressure. These occur because of the loss of the normal size and charge filtration of the glomerular capillary and the Bowman capsule interface. Causes of nephrotic syndrome include minimal change disease, membranous nephropathy, focal segmental glomerulosclerosis, minimal change disease is the most common cause of nephrotic syndrome in children and can be idiopathic, triggered by recent infection or immune stimulus. Patients classically present with patients classically present with dependent edema in the buttock, lower back, and legs, foamy or dark color urine, hypoalbuminemia, hyperlipidemia, and proteinuria. Complication include hypercoagulability caused by urinary loss of protein such as antithrombin 3, functions uh, to inhibit which functions to inhibit coagulation factor 2, 7, 9, 10, 11, 12. Deficiency of antithrombin 3 leads to hypercoagulability and would put to this patient at high risk thrombotic conditions such as DVT. Patients of nephrotic syndrome are also at increased risk of infection because of urinary loss of gamma globulins. Okay. Okay, can you give me 2 minute
Okay.
break? I'm coming.
Yeah.
Okay.
Yes.
Okay.
The man brought to the ED unconscious 30 minutes after car accident. Temperature is yes fine, a bit low. Pulse is high, respiration normal, palpable systolic. BP is 60. Exam shows multiple laceration and contusion over the trunk and upper and lower extremities, and abdominal distension. After administration of IV fluids, splenectomy, and transfusion of 4 units of red blood cells, his condition stabilizes. 24 hours later, pulse is 88 and BP is normal, I guess. Abdominal exam shows normal appearance, surgical incision. Over the past 12 hours, his urine output has been 100 ml. Labs, serum, sodium is fine, potassium is fine, urea is high, and then creatinine is high. Urine, molarity is 280 and sodium is 70. I don't know what that means. That is sodium. I don't know. What that means. Which of the following is the diagnosis? Oh, it's true. The billion. Billion invasion.
Like urine sodium and urine osmolarity goes with the pre-renal and renal, isn't it?
Necrosis, hypovolemia. Urinary tract obstruction. What's the normal urine sodium? I don't know.
Normal urine sodium. I don't
Mhm.
know either.
I have no idea.
But
But we know it's not,
like if we
we know
think
it's not.
about, yes, you say
No, you. We know it's not pre-renal. It's not pre-renal azotemia because BUN creatinine is 13.6.
in pre-renal to happen, yes, BN creatinine should be more than 20 or 15.
Okay, so we know it's not hypovolemia,
Okay.
and we know it's not transfusion reaction because the blood pressure is it? It's
Urine
not.
osmolarity, if you think about the renal, like
Mhm.
intrarenal by intrinsic renal, in here the osmolarity should be less than 300 and urine sodium should be more than 40.
Sodium should be more than 40. So you think it's
Intrarenal,
okay. So you
mm,
think it's intrinsic.
I think it is
It's
ATN.
intrinsic.
Yes, it is intrinsic.
Okay, let's go with that one. Next is 32.
If it
And
does
you
not
are
go,
right.
if it was wrong, then I need to jump from uh,
So the
somewhere.
normal urine, so you say, I guess it's 40. since you okay.
No, no. In pre-renal, urine sodium is less than 20. I don't know actual
Renal.
the urine sodium.
Oh, oh. Mm-hmm.
Can you see somewhere like in the
Yeah.
like pre-renal azotemia to happen? Pre-renal or intrinsic renal or renal azotemia, we actually see four things like urine osmolarity, urine sodium, FeNA, and serum BUN by creatinine ratio. In pre-renal azotemia, usually urine osmolarity is more than 500 and urine sodium is less than 20, FeNA is less than 1, and BUN by creatinine ratio is more than 20.
Okay, so I think the normal is 20.
Okay, normal is 20. So in pre-renal, urine sodium is less than 20, but in renal, in case of renal, urine osmolarity should be less than 350 and urine sodium is more than 40. FeNA is more than 2% and BN by creatine ratio less than 50. Okay, these things we need to remember. We need to- Okay, this block looks like renal. Okay,
Yeah.
sorry, I haven't read the explanation. I have gone to say second question. Okay. Acute tubular necrosis is a cause of intrinsic renal failure. Acute tubular necrosis is a cause of intrinsic renal failure that is most commonly the result of either ischemic or nephrotoxic insults to the kidney. This patient presents after traumatic hemorrhagic shock with hemodynamic instability and signs of hypovolemia. This increases the risk of ischemic injury to the kidneys secondary to decreased renal blood flow, which can lead to tubular epithelial cell death and sloughing into the lumen of the tubules. So these typically results in initial oliguric phase. These typically results in an initial oliguric phase where the patient is at increased risk for uremia, hyperkalemia, and metabolic acidosis. Following following this initial phase, the patient will then enter the patient will then enter into a polyuric recovery phase characterized by excessive urine production with association with associated falls in creatinine and risk for electrolyte imbalance, especially hypokalemia. Urine analysis typically discloses granular muddy brown cast, though not seen in this case. The presence of blood and protein in the urine. The presence of blood and protein in the urine may indicate an additional underlying pathology in the trauma patient, such as rhabdomyolysis from compression necrosis of the muscle caused by trauma or compartment syndrome.
And you
Okay.
would see the
Yes. Interstitial nephritis most commonly present. Interstitial nephritis most commonly presents as hypersensitivity reaction following exposure to certain medications such as penicillin, diuretics, sulfonamide. It can also occur in the setting of autoimmune disease such as SLE. It typically presents with pyuria predominantly. Eosinophilic transfusion reaction are variable and can involve febrile transfusion reaction secondary to preformed cytokine in the transfused blood, hemolytic transfusion reaction related to inaccurate cross matching or admission or administration of an incorrect blood type to this patient, or anaphylaxis, which would be characterized by tachycardia, wheezing, hypertension, angioedema, itching, urticaria, Nausea, vomiting, diarrhea. This patient is not exhibiting any signs. This patient is not exhibiting any signs or symptoms or lab values, making a transfusion reaction less likely. Making a transfusion reaction less likely. E. Urinary tract obstruction, in which settings such as nephrolithiasis, fibrosis, infection, BPH, or ureteral obstruction, which can result in post-renal azotemia from impaired urinary drainage. This patient is young and has no clear predisposing feature for the development of urinary tract obstruction, making it less likely to be the cause of the oliguria.
Next. Men with osteoarthritis come to office because of 2 week history of increasing right knee pain. Jesus. He was diagnosed with osteoarthritis 5 years ago. Last year, an X-ray of the right knee shows mild degenerative changes. He has been treated with increasing dosage of ibuprofen and now takes like a lot of ibuprofen 3 times daily. He tries to avoid walking because of the pain. He has not had abdominal pain or change in appetite or other symptoms. The temperature is fine. On examination, flexion of the right knee is limited to like 20 degrees. There are no effusions. Reminder of the exam is fine. Hemoglobin, I believe that's low. Leukocyte count is normal. Urea is high and creatinine is high. Let me check hemoglobin. Hemoglobin is actually fine. Urine, blood, negative, protein, negative, RBCs, none, and white blood cells, none. Most appropriate next step in management. Mm, 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 mm. Mm, mm, mm. Mm. BO and creatinine 32 over 3. Increasing right knee pain. Just continue in grams an hour. So the cup save.
Should we switch?
Probably.
Because decreasing the dose will not gonna improve his creatinine either,
Yeah, probably straight.
isn't it?
Yeah, makes sense.
Okay,
Next.
let's see.
See.
You are right.
Yeah.
So, acute kidney injury. Acute kidney injury, a rapid decrease in renal function may be caused by prerenal intrinsic and postrenal may be caused by prerenal intrinsic and postrenal causes. Non-steroidal anti-inflammatory NSAID medications such as ibuprofen are inhibitors of cyclooxygenase enzyme, which have a primary role in the synthesis of prostaglandin and prostacyclin. These molecules play key roles in the modulation of pain sensation and thermoregulation, and the maintenance of gastric mucosal barrier, and the regulation of the renal blood flow. If NSAID use occur at higher dose with more potent agents or over prolonged time, acute kidney injury can occur because of deficiency of prostaglandin, which would otherwise promote renal afferent arterial vasodilation and renal blood flow. AKI sustained in this manner is especially likely If high-risk NSAID use is accompanied by renal blood flow limiting pre-renal insult, such as volume depletion, NSAID can also cause intrinsic acute renal injury through the risk for acute interstitial nephritis. AIN is characterized by declining AIN is characterized by declining urine output and declining urine output and AIN characterized by declining urine output and glomerular filtration rate, rising creatinine, eosinophilic infiltrate on renal biopsy, and eosinophiluria. It is often associated with the rash. It is often triggered by medication including NSAIDs, diuretics, antibiotics. In this case, these patients rise in indicating AKI is likely caused by ibuprofen use, which should be discontinued.
82 men comes to physician because 1 month history of urinary frequency and dripping of small amounts of urine. He has not had pain with urination or fever, alert and oriented, pulse is fine, temperature fine, respiration fine, BP high, rectal exam shows enlarged, smooth non-tender prostate. Remainder of the exam is fine. Bladder catheterization shows a post-void residual volume of 750 ml. Urinalysis within normal limits. Which of the following was most likely cause of the incontinence?
Is it overflow?
Is it what? Urin-
The- Vital residue is high.
Ready?
Wait, 1 second. Debtors are overactivity or increased
Mhm.
underactivity, overflow, oh, underactivity, under, mm, obstruction, okay,
Okay. Mm, okay.
okay. Urinary retention, nighttime overflow, urinary retention, nighttime overflow, and an enlarged prostate and a weak urine stream. Urinary retention, nighttime overflow, incontinence, enlarged prostate, and a weak urine stream are characteristics of BPH in older men, which can lead to bladder outlet obstruction. The best next step to relieve the the best next step to relieve a bladder outlet obstruction involves catheterization to decompress the urinary bladder and prevent acute complications of prolonged and prevents acute complication of prolonged bladder outlet obstruction such as bladder rupture, urothelial cell atrophy or necrosis, hydroureter hydronecrosis, post-renal azotemia, and/or renal failure. A post-vital a post-vital residual volume of urine should generally be less than 50 to 100 ml, and significant urinary retention beyond 200 to 250 ml, though clinical guidance vary, is a generally an indication for placement of urinary catheter to relieve obstruction.
67. Man comes to physician because 2 day history of fever, nausea, and continuous urge to void, and progressive difficulty with urination. Every 30 minutes, he passes a small amount of urine. He has an uncomfortable burning sensation. He says he has slept poorly during this period. Prior to the onset of his current symptoms, he had 12-week history of difficulty initiating urine, a urine stream, and awakening 2 to 3 times a night to urinate. Okay. He has no history of serious illness, takes no medication. Temperature is high actually. Pulse is normal. BP is high. Cardiac exam is fine. Abdominal exam shows suprapubic fullness. Where am I? Rectal exam shows symmetrically enlarged prostate with no tenderness or masses. Labs. Hematocrit, I believe, is normal. Leukocyte count is normal. Platelet count is normal. Sodium is low. Potassium is high. Chloride is normal. Bicarb is normal. It's a bit low. Urea high. Glucose, I believe, is normal. Creatinine high. Urine, glucose negative, protein 1 plus, RBCs a lot, 30, white blood cells a lot. Which of the following is the most appropriate initial step in management? What am I? Oh, ready?
Mm, yes.
Where am I? Okay. Okay.
The patient's urinary retention nighttime. This patient's urinary retention nighttime overflow incontinence and enlarged prostate and a weak urinary stream is suggestive. His weak urinary stream is suggestive of bladder outlet obstruction from BPH. Bladder outlet obstruction of BPH as shown in this patient. BPH can result in complications such as urinary tract infection evidenced by fever, dysuria, white blood cell on urine analysis. In addition, severe bladder outlet obstruction can result in post-renal acute kidney injury and increased serum creatinine level. The first appropriate next step is to relieve the bladder outlet obstruction by placement of urinary catheter. The already narrowed prostatic urethra, if affected by secondary inflammation or infection, can result in near complete bladder outflow obstruction, impaired drainage of the bladder, and the urethra predisposed to infection by limiting urinary washout of ascending infection of an enteric organism.
You read A and F.
Yes, ultrasonography. Ultrasonography of the kidney would be helpful. Ultrasonography of the kidney would be helpful in evaluating for severity. Ultrasonography of the kidneys would be helpful in evaluating for severity and laterality of hydronephrosis in the setting of urinary tract obstruction, but would not be an appropriate first step. It should be focused on urgent treatment of the outlet obstruction. Similarly, CT scan of the pelvis can help here with identifying and characterizing anatomical causes of outlet obstruction, but further diagnostic strategy should not take priority over alleviating obstruction.
Oh, sorry. Sorry. Sorry, go ahead.
No, no. Which one?
Oh, that's it. We're done. Okay.
Yes.
Mm, Next. Previously healthy 20 woman comes to ED because 7-day history of vaginal discharge and 3-day history of postural lesion over chest and arms. 7 and 3. She has been sexually active with a new partner for 2 weeks. They do not use condoms. Only medication is OCPs. Arrival temperature is high. Pulse is normal. BP just normal. Exam shows approximately 10 postular region over the thorax and upper extremity. Pharmacotherapy.
Can
Oh.
pustular lesion over the thorax and upper extremity. The thorax and upper extremity. What he have?
The only thing that I don't think chlamydia can cause
Oh,
any
I'm thinking that is it DGI?
what is DGI?
Diffuse gonococcal infection.
Oh, I'm like, what is it? I mean, I get, yeah, I mean, yes,
These days I'm just thinking about the short things.
the shortcut there.
DGI, AAA, TAA, like that.
Yeah, but yeah, it sounds like it.
But
Ready?
yes, Neisseria gonorrhea can cause vaginitis, cervicitis, pelvic inflammatory disease in patient. It can uh, it can cause multifocal dermatitis that typically presents with tender macular or pustular lesions, along with tender macular pustular lesions, along with disseminated and migratory polyarthritis. Risk factors for PID and other sexually transmitted infection include adolescence, multiple sexual partners, and not using the barrier contraception such as condoms. Vaginitis presents with vaginitis typically presents with mucopurulent discharge and pruritus. Cervicitis presents with similar discharge but also with erythematous friable cervix, cervical motion tenderness. On examination, when the infection spreads to the fallopian tube and ovary, PID with purulent cervical discharge, uterine and adnexal tenderness, and systemic symptoms such as fever can result. If left untreated, PID can be complicated by tubo-ovarian or intra-abdominal abscess presenting with focal tenderness and fluctuant mass. The antibiotic treatment of Neisseria gonorrhea infection involves the use of third generation cephalosporin such as ceftriaxone as well as concurrent treatment of Chlamydia trachomatis with doxycycline.
Okay, next. 28 woman comes to office because 8 week history of fatigue and cold intolerance. 8 week. She has 2 year history of bipolar disorder. At the age of 4 years, she has hospitalized for 2 days for treatment of meningitis. At the age of 16, oh Lord, she had loss of consciousness after a motor vehicle accident. Her medications are it's the second time I see this thing. Divalproex and oral OCP and multivitamins. Her brother has type 2 diabetes, not smoking. She drinks 12, 12 ounces of beers daily and smokes marijuana 4 times. So she drinks a lot, I guess. She appears well developed and well nourished. Temperature is fine. Pulse is actually low. Respiration fine. BP fine. Thyroid gland is non-tender and cannot be palpated. So I guess there's no thyroid issue. Tendon deep reflexes are 2 plus or normal. Reminder of the exam is fine, including cardiac exam. Serum study showed TSH is 23. Wait, TSH 23 is actually high. And free thyroxine is low. So TSH is high and yeah. Which of the following historical factors has most likely increased this patient risk for recurrent symptom? What has increased the risk for recurrent symptoms? Hmm. 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 Meningitis. And between current medications and motor vehicle, family history. Hi, jeez, family history. Or family history. Motor vehicle. The thing will be low. No, that's not them. And then family history. Then that will be current medication. Is the Valpress the same as lithium? Do you know?
May not be.
May not be. Uh,
You
between
can
family
search the
history.
devel prox.
I don't want to cheat.
It's not cheating.
Ah, family history.
I
If
don't
she
think
had
so.
issue
It's
with,
medication.
okay, then it's family history. Okay, let's do. Ready?
Yes.
37. Yeah. Hmm.
This patient's family history of a brother with type 1 diabetes mellitus, the most important historical clue because it suggests an increased risk for familial autoimmune disease. While there are many varieties of the thyroid disease that can lead to hypothyroidism, the most common cause of hypothyroidism in iodine replete parts of the world, iron replaced part of the world is Hashimoto thyroiditis, also known as chronic autoimmune thyroiditis. Lymphocytic infiltration of the thyroid gland leads to cytotoxic destruction of the gland and subsequent fibrosis, which results in hypothyroidism. Patients may either have patients may either have a goiter or a normal sized thyroid gland. The diagnosis is made by measuring the TSH concentration, which will be increased, and the free T4, which will be decreased. The pattern indicates adequate secretion of the TSH from the pituitary gland, but inadequate production of thyroxine in the thyroid gland. In some cases, patients may have antibodies against thyroid peroxidase or thyroglobulin, although although these are not required for diagnosis. As this an autoimmune disease, patients with a family history of other autoimmune disorder such as type 1 diabetes mellitus and primary adrenal insufficiency are at greater risk of developing chronic autoimmune thyroiditis. Treatment is with thyroid hormone replacement in the form of levothyroxine.
Okay. Next. 42 women admitted to the hospital because one month history of burning and tingling of the skin. 1 month history, burning and tingling of the skin over all extremities and fatigue. She has hypertension and chronic low back pain. Only medication is thiazide. She appears tired but is not in acute distress. Temperature is fine, pulse fine, respiration fine, BP fine. Tapping over the facial nerve produces involuntary contraction of the ipsilateral muscles. Reminder of the exam is fine. Sodium is fine. Potassium is fine. Chloride is fine. Calcium low. Phosphate, what is it? Is high. Protein is total protein, sorry, is high, and albumin is normal. So this is high, high, and this is low. Which of the following is the most likely explanation for this patient condition?
Is it it is hypocalcemia, isn't it?
Hypo. Mhm.
So is it primary hypoparathyroidism?
I don't think so, but maybe, but I don't.
You are
Doesn't look
thinking
like.
about any syndrome, or is like that?
What
Pituitary,
syndrome?
like men, pituitary pancreas parathyroid.
Not really. Talking
Uh,
about the that one from yesterday. Oh my God, that one from the the crab.
Hypercalcemia crab, multiple myeloma.
Wait, no, the one that oh, that's hypercalcemia. It's not hypo. Huh?
Yes,
It's
it's
hyper.
hyper. Yes, crab is for
Okay.
hyper.
Okay, no, it's not that one.
Think
But why?
in the easiest manner, then you will get the answer.
Intensification of PTH.
I am already giving you the clue.
Efficiency of PTH. Efficiency of PTH. This doesn't make sense. Excess. Okay. Okay. Ready?
Yes,
It should be. Oh my God.
it's hypoparathyroidism. In
Uh,
hypoparathyroidism, PTH is low, calcium is low, phosphate is high. So you are you are you have already told like which one is higher and which one is lower. Okay. Deficiency of the parathyroid hormone, also known as hypoparathyroidism, also known as hypoparathyroidism, likely explains the patient's symptomatic. Also explain this patient's symptomatic hypocalcemia. PTH is a peptide hormone that increases. PTH is a peptide hormone that increases osteoclast activity and bone resorption to maintain calcium homeostasis. It is produced by four parathyroid glands, which are located on the posterior aspect of the thyroid gland. Primary hypoparathyroidism can occur following an unintentional resection of the parathyroid gland during thyroidectomy or may be caused by autoimmune destruction of the parathyroid gland. Primary hypoparathyroidism results in decreased concentration of the PTH, which leads to hypocalcemia secondary to inadequate bone resorption. Secondary to inadequate bone resorption, hyperphosphatemia, and decreased concentration of 125 dihydroxyvitamin D calcitriol, because PTH stimulates renal conversion of 25 hydroxyvitamin D to its active form. Decreased concentration of calcitriol substantially worsen hypocalcemia, as calcitriol directly stimulates intestinal calcium absorption. Signs and symptoms of severe hypocalcemia may include perioral paresthesia, carpopedal spasm, laryngospasm, prolonged acute interval, Gavostic sign in which tapping of the facial nerve leads to spasm of the facial muscle and the trousseau sign, in which inflated blood pressure curve occluding the black inflated blood pressure curve occluding the brachial artery causes carpopedal spasm, and the two physical examination signs that may indicate hypocalcemia treatment of a primary hypoparathyroidism, in which calcium and calcitriol supplementation to achieve low normal calcium level. Okay.
Okay. 32 women gravid at one para one comes to physician because she has not been able to conceive for 12 months. Her son was born 4 years ago. Her menses were normal until 1 year ago when they became irregular. She has not had a menstrual period for the past 6 months. She has also had a small amount of milky secretion from the breast. She doesn't take any medication. Vital signs normal. Exam shows normal, no abnormalities except galactorrhea. Serum prolactin concentration is 200, which I believe is high. Pregnancy test is negative. Most appropriate next step. Let me check. I'm guessing prolactin is high. Let me check. Yes.
Okay.
Okay, ready.
It's prolactinoma,
Okay.
isn't it?
Um, why? Yeah,
Yes.
probably.
MRI of the pituitary gland is MRI of the pituitary gland is more MRI of the pituitary gland is appropriate most appropriate next step in the evaluation of this young woman with amenorrhea galactorrhea. Amenorrhea galactorrhea increased serum concentration of the prolactin. Prolactin is a hormone that is produced and secreted by anterior pituitary. Normal increases in increased prolactin occur during pregnancy and immediately following delivery when infants begin to breastfeed, but concentration return to normal several weeks after delivery even as lactation continues. Pathologic increase in prolactin concentration are commonly the result of pituitary adenoma, resulting in hypersecretion of the prolactin from the lactate trough, while dopamine antagonists such as antipsychotic medication or SSRI may lead to mild increase of prolactin concentration. They do not approach the concentration seen in the pituitary adenoma. Prolactin inhibits the release of gonadotropin-releasing hormone GnRH and thereby reduces the concentration of thereby reducing the concentration of the follicle stimulating hormone and luteinizing hormone, which leads to amenorrhea and infertility. Directly Prolactin also acts directly on mammary glands in the breast and induce lactation, although galactorrhea is less common in the premenopausal woman after medication are excluded as the potential causes. Patients should undergo MRI of the pituitary gland to assess for the presence of a mass. In most cases, the first-line treatment is with cabergoline dopamine agonist, which decreases secretion of the prolactin. This medication is routinely used for women who desire pregnancy, as in this case, although bromocriptine is reasonable alternative. In rare circumstances, transfemoral resection may be required. Okay.
Okay. Yeah. 32 woman comes to ED 12 hours after sudden onset of fever, diffuse muscle and bone pain, and dizziness. She has no history of serious illness, no
How many
medications,
blocks
temperature
you
is.
do per day?
How many what?
How many blocks you do per day?
I try to do the one with you and one more.
Okay.
So like
And
whatever I do with
every day
you.
your tutor like make you teach.
He teach me, yeah, every day.
For how many
Um,
hours?
for 1 hour, usually 1 hour.
Okay.
But we are
So
finishing. We are doing poisoning and stuff, so we're done. He wants to go over dermatology again because he says that there is a lot of I don't know where he saw it, but he says that lately there's been a lot of dermatology on the step, so he wants to go over dermatology again. I
is
haven't been checking the comments on,
in
on Google.
the as far I remember in the Reddit there is nothing this type of there is
About that.
they haven't said these things. Okay, I'm
Me too.
checking
I haven't seen it, but
Reddit every day.
yeah, me too. I haven't seen it. I mean, I've seen the ethics one, but I haven't seen that. But he says, yeah. But it seems like he also teaches other students because I don't know. He seems like he also teaches some like other students. So maybe one of his students told him,
Okay,
like,
maybe
yeah, there was a lot of
there may be a lot,
maybe. Um,
or
yeah.
he's
So he,
preparing for like is he's preparing for step three.
I thought so, but he just told me that he's applying also this this upcoming the thing that's coming, the match cycle that's coming. He's applying. So
Oh,
I don't know if he's planning on taking the step three before. I don't know. He hasn't told me. And I also know that he works at a hospital there, but I don't know. He hasn't told me about if he's preparing for the step three. I don't know if he will need it because he got a really good score on the step two. So I don't know
uh,
if he tried to take it
okay.
before.
He's a recent graduate or old graduate.
I don't know. I just know he just took the step two, but I don't know if he's a recent graduate. I don't know.
Okay. People need step three. La, the IMG people need step three. But if we, as you are and US, uh, as you are US citizen, so you may not need the step three. You need to
Oh no,
complete.
I need it. I know I needed me specifically because I felt so I know it will look good on my thing if I think. But yeah, probably US citizens probably don't. It's
US
less,
citizen like step one and two is enough, and step three
it's enough. Yeah.
should be given within 1 year of the residency, like
But
after
they, yeah,
matching,
mm-hmm.
as far I know.
Even if even if I probably hopefully let's pray to God. Even if I match, I pass this and I match this year, I think I'm going to take step three before before next year. I'm going to just so just to get it
If
over with.
would be very tough because if you apply for this year,
Uh-huh.
it will take huge time.
No, but like let's say I apply and then I get the interview and everything is fine.
Mhm.
I can still study for step three. Even if I match, I can still study.
There, like in interview has lots of study. Truly,
Really?
truly, you don't know.
Oh.
One of my friend is applying, so I know there is
Mhm.
plenty of preparation you need. You need
Oh.
to you need to say you need to make lots of question memorize and try
Oh,
to
I
tell
heard that.
again and again because it would be very
Mhm.
tough.
Yeah, I heard that. I heard that there
And
is like
they
something else.
will not just ask you the medical question, like
No.
they will ask you about what's your why you are here, like if this type of
Mm-hmm.
thing, if you want to say in front of an examiner, it would be very tough.
Yeah. Okay. Okay.
Okay,
I
I'm
still
not
feel like
I am, as I
no,
haven't
I
done.
get what you're saying, but I feel like it will be, look good if I tell them like, I'm studying for my step three. I want to take it before I start
This
residency.
type of words, they will not gonna count. If you
No.
just say that I'm studying for step 3, then they will say, what have you done then? Why you haven't finished and then apply? So don't fall on those type of trap. Just say
Okay. Okay.
simple words and trying to show your enthusiasm to the examiner. Okay. Okay, I am
Okay.
talking like I am taking your.
Listen, we have to first pass this thing before we get there.
Yes, we are
Before we even get
very
there,
far behind.
far from there, we have to first pass the exam before we get there. But no, I feel like we're gonna pass. Now that I'm doing questions with you, it would be nice if you could be in the exam with me. We could take
But
the
it will
exam
not
together.
gonna help if I sit beside you. Even if I sit beside you, that will not gonna help to you.
No, I feel like no, Omar. If we sit next to each other, oh, for real, we're passing that exam. Because it seems like there are some questions where you don't have no idea, and then I help you. There are some questions where, like the calcium that we just did. I had no, I don't know if my brain was just
No, no.
frozen,
It
but you,
what happens like I like some questions that I do miss. Some questions that I have done wrong. Like it was not a difficult question for me. Sometimes I found that it was not a difficult question. It was the
mm-hmm,
thing that the the spark that hasn't come on that particular time. Like you know the topic.
mm-hmm,
Nowadays I
mm-hmm,
try what
mm-hmm,
I try to do. I read the question and I try to do what should be the diagnosis. What should be the diagnosis? For doing that, before looking at the option, why? Because I try to catch up some key points from that question. You got my point. That's why I sometimes I told sometimes I tell you that
mm-hmm.
how you pick, like what have you seen.
Yeah, that the mm-hmm, I get what
So
you're saying.
what you have seen, if I can see on that particular moment in the exam, we can tackle the question. You got my point.
Yes.
That was the tricky part. Like you can read these things. If we have the opportunity of reading this question 5 to 10 times, then after reading 5 to 10 times, you will get the clue. But just reading once, if you get the clue, then you can pass the exam or you can excel in the exam. You got my point. What am I trying to say?
Yeah, but definitely if you were there, we could take the
No, no,
exam
I
together.
am very bad student. And
Yeah.
in the exam, if you see me in the exam, you will be astonished what type of mistakes I have done in my. I know everything, but my brain stops working. Even if in the MBBS it happens,
Yeah. No, we will get
like
like three.
in front of the examiner, I don't know what happened. Okay, so
Mhm.
leave these things. Okay, start studying. We have to finish this block today.
Yeah, let's finish. Okay. Let's do this question and then like a 5 minute break.
Okay, yes.
Okay. 32 women comes to ED 12 hours after the sudden onset of fever, diffuse muscle and bone pain and dizziness. She has no history of serious illness, no medication. Temperature is high, pulse is high, BP low, while supine. Palpable systolic blood pressure is 70 while sitting. Exam shows diffuse red macular rash over face, strong hands and feet. There is desquamation over the palms and hands. Lungs are clear. Cardiac exam, no murmurs. There is 1 plus peripheral edema bilateral. Pelvic and urologic shows no abnormality. Most appropriate next step in treatment. Wait, what is happening? Uh, Storage BP.
Temperature,
She has some kind of like,
palpable system, discommation. There is this problem. The palms and is it thyroid problem?
think so. I thought it was like some kind of septic shock.
Where is the hypotension? It may
the,
happen,
the
but
disquamation of the hands and soul. What is it?
yes, this
So
in septic shock, you will not gonna found this.
no, it's oh, there is no disquamation, right? In septic shock.
And there is fever potential.
Okay, I'm just gonna go, but it looks like septic. I don't know, maybe not. Okay,
BP
ready?
is BP is low. I
A bit
think that
slow,
I
but
think
still
that we
good.
need to give fluid first.
Okay, ready?
It may be septic shock. It is a shock. So that is
It
it.
is some kind of shock. I just the
So
disquamation.
fluid. Y- Toxic shock syndrome.
Yeah, ready?
Yes.
Yeah,
This
it was.
patient presents with signs and symptoms of toxic shock syndrome. Toxic shock syndrome toxin produced by Staph aureus. Produced by Staph aureus causes a cytokine storm which causes dysfunction of multiple organ can lead to distributive shock and death. Patients typically present with fever, hypertension, diffuse erythematous discommission, and clinic and lab evidence of end organ dysfunction, such as altered mental status, myalgia, thrombocytopenia, azotemia, and transaminatism. Toxic shock may be rapidly fatal, even with appropriate treatment. Treatment includes administration of appropriate antibiotics, aggressive hemodynamic support, IV fluid, and the support of end organ failure. Source control such as pelvic examination to remove a retained tampon, and it is important to limit further release of toxin. Okay,
Can you read DE? This one.
yes. IV metronidazole and penicillin are inappropriate antibiotics and would not appropriately treat a Staph aureus infection. Metronidazole is an antibiotic used in the management of anaerobic infection, nearly Clostridium difficile and Giardia lamblia. Uh, Penicillin is an antibiotic used to treat various gram-positive spirochetes infections. Staph aureus is resistant and is most penicillin because of its penicillinase enzyme that cleaves the beta-lactam ring, the penicillin molecule. Okay,
Okay, let's take a ten
break.
minutes
Okay,
break.
okay. One thing I want to say you.
My screen.
Mm, yes, now.
Were you timing yourself when you were doing those CMS forms?
Sorry.
When you were doing the CMS forms, did you time yourself? Did you like put a timer,
In
or
here,
were you not like when you were doing the CMS forms? Like were
previously.
you? Uh huh. Uh
No,
huh.
no, I haven't. Timing problem I haven't solved yet because these days I am very frustrated and
I'm
my
I'm
mind
I'm
does not work that well. That's why.
I'm freaking out because I'm all the ones I've done. I'm not able to finish on time. I always have like
Yes.
5, 6 minutes left. So
That's
that's
happened in the NBME, and I have found that this is this is a crucial thing. Like if you like I have seen that like that questions the last questions was easy and
yes, yes,
and
yes.
I actually waste time on hard questions which I cannot make it and the that actually waste my time too. So I need to like change my temptation also. Like I need to skip some questions that I don't feel that it will not gonna possible. Like I can make it. You
Do
got
you
my
also
point.
think that? Yeah. Do you also think that maybe like because it's 50, because the actual exam is 40 per block. Do you think that maybe because this is 50, that's why we're running out of
No,
time?
no. That
No.
these questions are pretty much short than the actual uh, like in the actual what can I say, actual e-world question. E-world question is very tough to read,
Mm-hmm.
but this question you can read 2 to 3 times.
Okay. Okay.
So it is not the like 50 questions. It is our, there are some people who actually are very fast in doing questions, even if they are doing this for the first time.
I thought I was fast. I mean, I thought I read fast, but I guess no.
No,
Ah,
no. Some people's like, there are some people's like 82 year and 3 week history. They actually read this type of way, like in the office and these and that. This is a waste of time. You got my point. 82
yeah.
year woman, 3 week history of bilateral frontal headache, 3 day history, pain, parietal skull region, claudication of the jaw. You are seeing that I'm skipping lots of things. So if
Mm-hmm.
you, I think that we need to start a reading question in that way.
I thought that's what I was reading. You don't see me. Sometimes I be like temperature good, pulse good,
Yes,
whatever. You
initially
know.
it has improved when we start.
Mm-hmm.
You are actually reading all the things. Now you are
Mm-hmm.
changing your pattern. Yes, I know that you are changing your pattern, but we need to change our pattern. um, we need to improve our skills on that pattern too. You got my
Jesus.
point, what I'm trying to,
Yeah.
like
Yeah.
on physical examination, we need not that there is tenderness in the temporal area. You got my point.
Mm-hmm.
uh, uh, from the next CMS form I will try to read, and
Okay.
okay, you will see that it is helpful or not, like it's a
Okay.
pattern of seeing questions.
Because I don't know how to solve that, and I know it's because I'll have 5, 6 questions left, and
If you
then
have 5 6 question left in each block, your
that's a lot.
mental, like your mental breakdown will happen after finishing the block. That mental
Yeah.
breakdown will cause to
Yeah.
make mistakes another 5 questions, so your 10 questions
Yeah.
will be lost.
Yeah.
Yes, I know that. I have already understand what is my problem.
Okay, 82 women comes to office because 3 week history of bilateral frontal headache and 3 day history of pain over the parietal skull regions. 3 week. Okay. She also has claudication of the jaw and tongue after she chews vigorously. Examinations of CBC 6 months ago were normal. Today temperature fine. No, temperature is high. Pulse is fine. Regular respiration fine. BP is high. Physical exam, there is tenderness of the temporal regions bilaterally with the left more tender than the right. Hematocrit, I believe that's low. MCV normal. Leukocyte count normal. Platelet count, I guess is high. Erythrocyte sedimentation rate.
Yes sir, is
Erythrocyte
high.
is high. Okay. Which of the following is most likely ophthalmic complication of this disorder? It's the most ophthalmic complication. Like hematocrit is low, right? Hematocrit, yeah, it's low. Frontal headache, pain of the parietal skull, claudication, jaw, tongue. Uh, very discolored ischemic viscosity dendritic, blah, blah, blah.
What is your
Is it
diagnosis?
the that one?
GCA,
Vasculitis.
temporal arteritis.
Yeah, one.
Yes.
Okay. Ready. I don't know how you remember those names. Sometimes I'm
No,
like, I
no.
know the diagnosis, don't know
Uh,
the name. I don't know
m-
the name is not
I
for me.
my way is like, what is your differentials? If you just read a question, like when you are in the, if imagine, just imagine if you are in the hospital and you, there is some patients and you have said all the history. The next thing your examiner or your mentor will say, what is your differential? So whenever you read the question, think about one or two differentials, then see the question, then you will then you can easily pick the answer.
It always takes me like I know. It's just the name
if
that
you
like
if
I know what it
if
is.
you just see the options first, what will happen? If you see the options first, then you will be distracted, like you cannot think apart from these boundaries. It is very good and it is bad also.
Mhm.
Have you ever done the usable rx?
Mm-mm.
usable rx has a option like usable rx coach. Do you know that?
No, I don't know.
Okay, in the RX coach, what actually they do, there is a mentor. He will help you to solve the questions. He will read the question, give you time, and then he will ask you what is your answer.
Mm-hmm.
So uh, that on that question reading pattern, you can see the video in the YouTube.
Mm-hmm.
On that question reading pattern, they actually start from here. Which of the following is the most likely ophthalmologic a complication? Then they start reading all the options, then they start reading the question.
You know, I tried. I did that. No, not the question, not the options. I don't know if it's divine. Somebody else, somewhere else, I heard that. Just
Yeah.
read the question, the last sentence first, and then read the question,
Yes.
not the answer. They say
Yes.
read the last question, read the question, the last sentence, then
But
read the
on
question.
that USML RX, if you
Yeah,
just you or go you in YouTube, there are plenty of videos.
yeah. They were like, if you read the last sentence, then you read the question, and
but
then you come up.
the USMLE knows that you are reading the last. That's why they change it
Mm,
this nowadays. So this tactics actually does not help.
what do you mean they change?
Like just reading the last line, you cannot pick the answer. If
No,
you
you don't read just the you read the last line,
hmm,
then you read the question on itself. But when you finish reading the question, you already know your because you already read the last line, you know they are asking for a complication. Then you already once you finish reading the question, you already know, okay, this is my complication that this is this. And then now you're looking at the answer. And now you're not looking at all the answer, you're just looking at the answer that you came up with in your mind. That's what you're
if you
looking for.
don't like if you are thinking about the complication, then you will unable to diagnose this disease. If you don't diagnose, because it is like two step or three step question. Like if you look at the step, one step is diagnosis, second step is complication, third stage is treatment, and fourth step is like the prognosis. So USMLE actually sets the question in the step pattern. So you need to pick up the step first. If you think about the complications all the time, you are unable to pick this question.
Like let's say this question, the last sentence was what is the diagnosis?
What is the most likely ophthalmic complication? Got
No,
my
I said
point?
yeah. I said, let's for example, let's say this last sentence was what is the
Mm,
diagnosis, right?
yes.
So you read the last sentence, it says what is the diagnosis. Then you start reading the questions, blah 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 blah. And as you read, you come up with, oh, it's temporal arthritis. Then once you done, you come in to read the answer choice. You don't read all the answer choice. You just look for the answer choice that says temporal arthritis and you pick that. You
Yes.
see what I say?
Yes. Okay.
Uh-huh.
So
That's kind of like
you can start reading in that way too.
no, I
No, no. why I am saying so, if you just if you do things repeatedly in the same pattern, you will
Yeah.
not improve. If you do things in a different pattern, you will improve. You uh, that's why I have said this and that. I am trying to make you accustomed with the Gemini and this and that, because
Mm-hmm.
like
Mm-hmm.
uh, if you are not satisfied with the answer, like in the
Mm-hmm.
CMS form, you are not satisfied with the answer, you can see and you can get the almost correct answer. Not always, we have
Mm-hmm.
seen so.
Mm-hmm. Mm-hmm.
So your idea will be broadened. So you need that. You got my point.
Yeah.
These days you are actually uh, picking questions that you are not satisfied with the answer. That means you are thinking,
Mm-hmm.
your thinking process has start. Initially we
Mm-hmm.
are just cramming, like this
Mm-hmm.
is that, this is that. So
Mm-hmm.
your mind is opening, so keep it open. It will help
Okay.
in the exam. You will see in the exam, because in the exam lots of things will not come to your, may not come to your knowledge, but you can
Yeah.
deal that. Okay,
Yeah.
lots of talking is going on. Okay,
No, it's good. I
no,
like it.
I am trying to like broaden your area,
Mm-hmm.
broaden your area of thinking. Okay, sometimes I do not get the words, so try to help me on finding words.
Okay.
Okay, granulomatous arteritis in cervical or temporal arteritis, and granulomatous arteritis in cervical or temporal arteritis are referred to as temporal or gynecal arteritis. Is a vasculitis that affects the large vessel such as aorta, aortic arch, temporal branch of the external carotid and vertebral arteries, among others. It is characterized by headache, temporal tenderness, jaw claudication, and fever. A potential complication includes monocular blindness from ischemic optic neuropathy. These occur secondary to inflammation and resulting thrombosis of the central artery and posterior ciliary artery. Because of the potential acute complication, this condition requires urgent administration of the glucocorticoid, ophthalmologic evaluation, and temporal artery biopsy for diagnosis. Administration of the steroid do not generally affect the biopsy results if biopsy occurs within 1 to 2 weeks. Mm, okay.
Next. 27. Okay, let me read the thing. In addition to smoking, which of the following is the most appropriate recommendation? 27 woman comes to physician because 6 month history of her hands and finger becoming tender and turning white to exposure to cough. 6 months. Symptoms occur 4 times monthly. She has not had any other symptom, no history of serious illness, no medication. She smoked 8 years. Exam shows no abnormality. Results of lab, everything is normal. In addition to stopping, yeah, most appropriate recommendation. In addition to stopping smoking.
Quartz, white. Is it Reynolds?
Probably, yeah.
Mm, pressing on resistance oxides.
Ready? What's daxazine? Is it alpha blocker?
Yes,
No.
doxazosin, prazosin, terazosin, doxazosin is alpha blocker.
It will work, but I never heard of it. It will actually work.
Alpha
I never
blocker,
heard.
does alpha blocker helps?
Does it? Oh, is it? It's
Mm,
calcium channel, but okay.
it is calcium channel blocker, isn't it?
Mm-hmm. That's true.
So, no, okay.
Okay.
So vasospasm causes intermittent loss of vasospasm causes intermittent loss of blood flow to the distal extremities in Raynaud's phenomenon, resulting in resulting in sequential white, blue, and red discoloration of the affected areas of the skin. The vasospasm associated with Raynaud's phenomenon can be triggered and exacerbated by cold temperature, stress, or emotional upset. Activities such as cigarette smoking, injury, trauma, or chemical exposure can put patients at a higher risk for Raynaud's phenomenon. Raynaud's phenomenon may be idiopathic or associated with mixed connective tissue disease, SLE, or CREST syndrome. When severe or prolonged ischemic injury can result in digital ulceration. Dressing warmly in cold weather can help to prevent Raynaud's phenomenon by decreasing cold exposure.
Okay. Next, diagnosis. 27-man works as a lawn maintenance service, is brought to emergency department by supervisor 10 minutes after he was found incoherent and wandering around the neighborhood where they were working in the late afternoon. Supervisor reports that the patient was fine when they arrived at work at 6 in the morning, but one could locate but no one could locate him after they took a lunch break at noon. Temperature is high. He takes over the counter histamine for allergies. Father died of MI at 39. Mother and sister have autoimmune thyroiditis. Is alert but not oriented to person time, not oriented. Temperature is high, pulse is high, respiration normal, BP, I believe that's normal. Exam shows warm, dry skin. Pupils at 4, which I think is normal, and sluggishly reactive. Um, yeah, diagnosis.
Is it heat stroke? I'm working in the late afternoon.
Warm, dry,
600, but no
and anti-hem.
blood pressure is not warm, dry skin, people 4 centimeters, sluggish, his mother and sister.
Ready?
4 millimeter, sluggishly reactive. Is it thyroid storm or heat stroke?
I pick heat stroke, but I'm not sure.
He's working. Okay. Uh, One thing. He's working in the afternoon.
He's working since 6 in the morning to late afternoon. I
Okay.
the way I'm thinking is and okay, go ahead.
Okay.
It's just heat
It is
stroke.
heat stroke. Initially, I picked heat stroke, then I changed my answer. Okay. It happens. Okay, no problem. Heat stroke is characterized by Heat stroke is characterized by an increased body temperature that occurs where when the body is exposed to high environmental temperature and high humidity. It commonly happens in young athletes and or in elderly patients with impaired thermoregulatory capacity. Excessive heat exposure and increased core body temperature lead to cardiovascular and neurologic dysfunction with secondary tachycardia, tachypnea, hypotension, vasodilation of superficial blood vessel may lead to shunting of the blood with the resultant multi-organ neurologic dysfunction with secondary tachycardia, tachypnea, and hypotension. Vasodilation of the superficial blood vessel may lead to shunting of the blood with resultant multi-organ system dysfunction, including neurologic impairment, hepatic or renal ischemia, rhabdomyolysis, DIC. Treatment includes cooling Treatment includes cooling of the patients with fan or ice water, continuous core temperature monitoring, and support the patient's airway, breathing, circulation. Uh, circulation, a patient must demonstrate neurologic symptoms to diagnose heat stroke, whereas heat exhaustion presents similarly but with an intact neurologic examination. In this example, the patient in a young manual laborer who works outside in the sun and his use of antihistamine, especially if it also has anticholinergic action, may also impair their ability to thermoregulate through sweat and cutaneous vasodilation. Okay.
Next. Uh, Immediate step in management. So management. 24 man who is employed as a landscaper is brought to the ED by coworker 20 minutes after he collapsed while walking in the garden. He had lightheadedness just before he lost consciousness. On arrival, he's responsive but unable to give medical history. Temperature is fine, pulse is high, respiration high, uh, systolic BP 70, oxygen 92. Wheezes are heard bilaterally. Which of the following? Yeah, next step in management.
Lost working in the garden lost. Oh. Is it shock?
Is it shock? Um, doesn't look like shock.
Co-worker 21 he collapsed while working in the
Oh,
garden.
you mean anaphylactic shock? Is
Yes,
that what you mean?
he
I'm
is
trying to
working in
look.
the garden. Something
Yeah, it looks
happens.
like this. Yeah.
You are.
Ready?
Do you thinking another thing?
No, that's what I was thinking. Anaphylactic. Mm-hmm.
Okay, then okay. Because I may
Yeah.
okay. Administration of epinephrine is most appropriate. Administration of epinephrine is most appropriate immediate step in the management. Mm, For this patient with presumed anaphylaxis should be suspected given diarrhea, hypotension, hypoxia, and wheezing, which is most likely indicative of bronchospasm. Anaphylaxis is a type 1 hypersensitivity reaction that develops following exposure to allergen. It is caused by widespread Ig-mediated muscle degranulation and is characterized by histaminergic responses within multiple organ systems leading to flushing, angioedema, bronchospasm, nausea, vomiting, abdominal discomfort, and vasodilation, which can lead to airway obstruction and circulatory collapse if not managed promptly. Death can occur from hypoxia or distributive shock. The diagnosis is made clinically, and the first treatment that should be given intramuscular epinephrine. Adjunctive management may include inhaled beta agonist, glucocorticoid, antihistamine blocker, fluid resuscitation, and potentially invasive airway or vasopressor support. Patients who present with signs and symptoms of anaphylaxis while working outdoors may have experienced B in a evaluation B evaluation regardless of the cause. Treatment is the same at the time of the discharge. All patients should be provided with epinephrine auto-injector and training how to use it. Okay.
Can you read A, B, D, and
Yes. Arterial blood gas analysis provides information about acid-base status and oxygenation. In this case, this patient has clear evidence of hypoxia and should be treated immediately with therapies aimed at reversing anaphylaxis. Arterial blood gas analysis is not necessary and would only cause unnecessary delays in treatment. Determination of eosinophil count is not necessary. Hypereosinophilia is a non-specific finding that is frequently present in patients with asthma and atopic disorder. This This patient is unstable and require immediate treatment. A, B, and D. Measurement of plasma histamine concentration can support the diagnosis of the anaphylaxis, but measurement should never delay emergent treatment of life-threatening condition. Okay.
Arterial blockers is most likely to show what?
Mm,
74 women admitted to the hospital following an MI. She's confused and has cool,
mm,
clammy skin. Over the next hour, BP decreases, so she goes into hypertension. Uh, what do you see? Arterial blockers.
MI.
She goes into um, metabolic acidosis.
Is it
Okay.
cardiogenic shock?
You said the MI. Oh, yeah, probably cardiogenic shock.
Is there anything related to shock like kind of acidosis? Okay.
I feel like it's either A can also be an option. But anyway, let's see. Oh, no, A is not an option. Mm,
Okay, following AMI, hypertension, altered mental status, hypoperfusion, cold, clammy skin is most likely caused by cardiogenic shock. Cardiogenic shock caused by decrease in cardiac output. Cardiogenic shock decrease in cardiac output often caused by infarcted or infected cardiac muscle. This leads to vasoconstriction of the peripheral vessel to maintain blood pressure and inadequate perfusion of the end organ. As organs begin to receive an insufficient supply of the oxygen, they transitioned they transitioned aerobic to anaerobic metabolism, which leads to production of the lactic acid. So lactic acid, okay. Excellent explanation. This lactic acid decreases the pH of the blood, leading to metabolic acidosis. This is often worsened in cardiogenic shock because of liver is unable to adequately metabolize lactate in the setting of decreased perfusion. Therefore, this patient has metabolic acidosis by production of lactate. Okay.
Uh, the bug that's causing the disease. 52 men brought to the ED because one day history of fever and chills. He received the diagnosis of small cell lung cancer 1 month ago and is undergoing chemo. A right subclavian central venous catheter is placed. Temperature is high, pulse is high, respirations are high, BP is low. Exam shows warm, flush skin, catheter site is lightly red. There is tenderness over the subcutaneous pocket. Leukocyte count is high, chest X-ray shows a nodule in the right upper lobe. Okay.
Squamous cell carcinoma. Catheter. Staminodymatis.
Fever and chills. Catheter. Ugh,
Is it according to sketchy catheter things? Catheter, heart valves, like should we think on that way? You got my point.
no.
Like in the sketchy, the man who is fixing the
Oh,
basic.
you're trying to go with epidermis, whatever, epididymis. Mhm.
Yes, is there any other thing you are thinking?
I
It
was
it
thinking
yes,
it's definitely the catheter that the infection went through, right?
yes,
And,
probably.
or either he's immunosuppressed because he's going to chemo. So it's either immunosuppression or catheter.
If
Candida,
he is immunosuppressed, what infection will happen in this
uh,
case?
either candida or E. coli if he's immunosuppressed.
O-
If it's the catheter, I don't think epidermis has anything to do. I don't think epidermis. I don't think it's epidermis. I think it's between candida and E. coli.
Okay.
I know candida happens in immunocompromised, but I'm not.
Yes, candida
Anyway.
can happen in immunocompromised. Candidemia, there is a word.
Oh, Martha, you were right. Follow me. You were right.
Previously, I made a mistake in the thyroid storm. That time I realized that don't think over.
You see, when I say we could take the exam together, we'll pass. We'll pass. Like, jeez.
Okay,
Oh,
so I am like talking too much because as you have seen all the sketchy things, you will remember like that the man is who is
yeah. Hmm?
fixing things and the woman who is showing her navel, the UTI woman. Don't think in a bad manner. I try to make you remember. Okay, start. Okay, bacteremia commonly presents with fever, tachycardia, tachypnea, hypotension, and leukocytosis, and can also be associated with altered mental status and end organ damage if it proceeds to cause septic shock or if it proceeds to cause septic shock when it can be a variety of the infection when it can be a variety of infections such as pneumonia or pyelonephritis. It is most likely caused by the patient's central line, given its erythematous and tender insertion site. Central line catheters are most often placed for the administration of the vasopressin in critically ill patient as an alternative for venous access in patients with difficult to obtain peripheral access for the long-term administration of medications such as antibiotic chemotherapy. Unfortunately, central line associated bloodstream infection and are a relatively common complication. Bacteria, most often skin flora such as Staphylococcus species, can be introduced into the bloodstream and can lead to bacteremia, especially in patients who are immunocompromised, such as undergoing chemotherapy. Therefore, the most likely causal organism in this patient is Staph epidermidis, a common cutaneous organism that can translocate and sit discontinuous in skin such as line site. Treatment includes IV antibiotics and removal of the line. Okay.
Unit A.
Yes. Candida albicans is a fungal organism. The most commonly causes of oropharyngeal candidiasis, esophagitis, vulvovaginitis, candidemia, or the invasion of the candida into the blood is rare and often only seen in immunocompromised patients with other risk factors including admission to the ICU, central line access, and the administration of total parenteral nutrition. However, candidemia often leads to severe sepsis with associated skin and ophthalmologic lesions, which this patient does not have. Okay.
Okay, next. Which of the following represents the most what?
Sensitivity. Okay.
Oh, which of the following represents the most appropriate sensitivity and specificity? of an additional test to confirm this patient's diagnosis. Okay, 37 woman comes to physician for HIV screening. She is asymptomatic, no history of serious illness, no medication, doesn't drink alcohol, no drugs. She has had two lifetime male sexual partners and they use condoms, so that's good. The exam shows no abnormality. ELISA is positive for HIV. Sensitivity of ELISA is 95% and specificity is 90%. Jesus. Which of the following represent the most appropriate sensitivity and specificity of an additional test?
Just to confirm the patient diagnosis.
I thought ELISA was the confirmatory one.
What
I guess
else? Oh,
to confirm.
is it Western
Oh,
blot? Like Western blot?
okay. So they are asking for a confirmatory test. So a
They are asking
confirmatory
for sensitivity and specificity of an additional. So, where is the clue? How will you proceed? How will I proceed? Okay, you are good at this. Just tell me how to do it.
is between those. They are asking for a confirmatory test, and for confirmatory test, the specificity should be high. So it's between here is 90%. So we are looking for something that's higher than 90%. So it's 95 to 90 or 99. These two are definitely eliminated.
Okay.
Now the sensitivity, I don't know. That's what I know it's between those two, but can both
So
of
you
them be
pick
90?
one, I pick one.
Okay. Can both of them be 99, 90? That would be like too high of a.
So you are
Okay, okay,
picking
okay.
C.
I pick it. Okay, I pick C. Fine. C.
Let's see.
Uh,
I just
it
follow
was
your
D.
footsteps. And I
It
got
was
wrong
D.
too.
It was D. But I knew for sure specificity has to be high. But I was like, that would be such a super good test that both of them at 99%. That's like so good of a test.
So they are.
But I,
Your explosion thing is good.
yeah, yeah.
Yes. So we are almost there. That is 50-50 chance.
Yeah.
So it is good. Okay. Sensitivity. Sensitivity and specificity are important concepts when determining which diagnostic test to utilize and how to interpret them. Sensitivity refers to the ability to sensitivity refers to the ability of a test to correctly identify those with the disease, whereas specificity refers to the ability of a test to correctly those identify those without a disease in a patient population with low prevalence of a disease. A negative result of highly sensitive test effectively rule out rule out the disease because there is low rate of false negative tests. Therefore, positive results of sensitive test must be verified by a highly specific test, which would be decreased risk for false positive result. Therefore, sensitive tests are often used for screening, as in this patient must be verified by a more specific test. Therefore, a test with 99% specificity would be most likely to confirm or refute this patient's diagnosis. Specificity is calculated as true negative divided by the sum of the true negative and false positive. Therefore, a test of 99% specificity would have only one false positive out of the 100 administered tests. Positive tests would therefore be more likely to be true positive. Okay.
Okay. Which of the following is the most important reason to be concerned about the author's conclusion? Not the biostats. Study is conducted to assess a possible association between regular use of alcohol and colon cancer. Cases consist of patients hospitalized with colon cancer. Controls consist of age and gender matched patients admitted to the same hospital for treatment of acute injury. Okay. Cases and control are interviewed after the condition stabilize. The researchers conclude that regular use of alcohol reduces the risk of colon cancer. What the fuck? Which of the following is the most important reason to be concerned about the author's conclusion? Cases, people with colon cancer. Okay, incident rates for alcohol use and non-user.
Like they are picking the patient who are coming for acute injury, not like the
Mm-hmm.
healthy people
Uh-huh.
who are in risk factor. Okay, inappropriate control group. I also think so. Let's see.
Yeah.
Okay, we are right.
Mhm.
A variety of methodological flow or study weakness can limit the application of study results to a general population. These flaws include confounding variables, inappropriate selection of case and control groups, inappropriate analysis of the data, and biases such as sampling bias or observation bias. In designing a case control study to determine relationship between exposures and the outcomes, it is it is important to choose a case group or a control group that are matched to eliminate or avoid confounding to strengthen conclusion that difference observed are caused by the variables being studied. For example, in this scenario, choosing a control population that consists of patients admitted to the hospital with acute injuries likely interferes with the interrupted results of the studies that the regular use of alcohol reduce the risk of colon cancer. This is because regular alcohol can lead to acute injuries during intoxication, and thus control group may have higher baseline use of alcohol compared to the case group. This has likely led to possible inappropriate conclusion in this study, and regular use of alcohol reduced the risk of colon. So therefore, the most important reason to be concerned about the author's conclusion of the study is inappropriate control group. Okay.
Okay. Next. Next step in management. 77 men has had intermittent confusion since transfer from the hospital to the hospice 6 days ago. BP ranges between 90 over 40 and 70 over so low during this period. He was treated in the hospital for MI, sustained 3 weeks ago. During the past 8 years, he has been admitted to the hospital 4 times for MI. He has been treated unsuccessfully for atrial and ventricular arrhythmia and has been unable to tolerate inotropic meds. He has had left hemiparesis since he sustained a stroke like 30 years ago. Physician has explained to him and his family that he is not a candidate for cardiac transplant or implant of a left ventricular assistance device. The patient has severe chronic back pain. His only medication is morphine. Patient's advance directive designates his daughter as his healthcare proxy, and the patient has explained he wants his daughter to make the decisions for him. The daughter says that the hospice care is insufficient in controlling her father's pain and asks that he be admitted to the hospital. Next step. Hmm. Admission to the hospital. MI. Ensure the patient spend control with the office staff. Okay. Feel like it's D. Ready?
Okay,
Feel like it's D as in dog, but let's see.
I have
Um,
chosen that. So
Yeah,
if
so
you are right,
it's-
I am wrong.
but D
I
looks,
thought,
yeah.
I
Yeah,
thought,
me too. I was
yes.
like, this looks the
Okay,
answer. Because the daughter is the healthcare right proxy.
yes.
Hmm.
Hospice, hospice care is a form of health care that aim to provide comfort and palliation to terminally ill patient in their last stages of life. As a terminally ill patient approaches the end of the life, they may decide to focus on the quality of remaining life rather than on increasing the quantity of time remaining. Hospice is a multidisciplinary healthcare model that includes physicians, nurses, social workers, chaplains, and aids to eliminate suffering and provide spiritual and emotional support to patients and their family. Goals often include treating symptoms such as pain and anxiety and providing a patient as much time at home as possible by avoiding further hospital admission. The patient has terminal heart failure associated with arrhythmia as well as hemiparesis and has opted to enroll in hospice care. Therefore, care should be taken to eliminate the symptoms related to the patient's chronic illness by discussing the patient's pain control with the hospice staff and rather than admitting him to the hospital again.
50. Which of the following best characterize this type of medical error? Bracket. 54. Men hospitalized because of 5-day history of chills and moderate pain, edema, and redness of the right foot. His symptoms began 2 days after he stepped on a nail. He has coronary artery disease, type 2 diabetes, hypertension, hyperlipidemia, no known drug allergies, medication, metformin, insulin, lisinopril, atorvastatin, aspirin, everything. Temperature is high, pulse is high, respiration normal, BP I guess high. Exam shows right lower extremity erythema, warm, tenderness to palpation from the proximal aspect of the ankle to the dorsum of the foot. Reminder of the exam, no, it's fine. IV vancomycin and piperacillin tazobactam is started and the patient home medication regimen is continued. While filling the prescription, the pharmacist notices a problem in the medication order. Investigation shows that the physician wrote the prescription in an immediate release formulation instead of an extended release formulation. Type of therapy.
Near miss. Okay.
Okay. Where am I? Yeah.
Okay, it's near miss. Medical errors. Medical errors are common in healthcare and are often the result of interplay of individual and systemic factors. They range from medication administration errors to failures of equipment, among a variety of others. These errors or mistakes may or may not reach the patient. Adverse events occur from medical errors that reach the patient and can cause unintended harm, whereas sentinel events are extreme form of these events that can lead to permanent disability and death. However, many safeguards are put into the place to prevent errors from reaching patients. For example, as in this case, the medication ordered by the physician is checked by the pharmacist prior to being dispensed, and then it would be further checked by the bedside nurse before it is delivered to the patient. These medical errors that do not reach the patient are transferred to as near miss events. Okay,
Can you read A?
yes. Active failure is a medical error that is caused by human error, such as negligence, misinformation, incompetence, or technical mistakes, and directly causes the patient harm. This error was likely caused by honest mistake in entering the medication and was realized by the pharmacist before reaching the patient, making it a near miss event rather than active failure. Okay.
Okay, we are done. Yep, I will see you tomorrow. Do you want to do the next? We only have one IM left, or you want to do MBME 14? Because we didn't ever